Good evening. My name is Karen Matlock, and I'm here to talk about the quality improvement, the workflow analysis of the stroke patient process in the emergency department. I have been in emergency medicine for over 15 years, and it's something that is close to my heart. So, what we're going to look at is the workflow of strokes in the emergency department and the nurse role. Strokes are either hemorrhagic or ischemic. In the United States, on average, a stroke takes place every 40 seconds nationwide. In westernized countries, strokes are the third leading cause of morbidity and mortality. 87% of strokes are ischemic and occur when there is a blockage in one of the blood vessels in the brain impeding blood flow. Hemorrhagic strokes are the other stroke, which occur when a blood vessel in the brain has burst. Treatment is time dependent in a neurological emergency. What we always say is time equals brain, therefore, quick recognition, diagnosis, and workflow treatment saves neurons. Signs of a stroke, we can use the acronym BFAST, which is balance, which is loss of balance or coordination, visual changes, a drooping side of one side of the face, weakness in a limb, difficulty speaking or understanding others. And at that point, if that happens, you need to call 911 or seek emergency services right away. One very key component of strokes is what time did the stroke start and when did they seek treatment. So the time of symptoms, or the onset of symptoms, determines the treatment options and long-term health outcomes. So the nurse role in the stroke patient workflow is very vital. A patient can either arrive into the emergency department by ambulance or by walking in. The nurse is to triage and conduct a rapid screening of symptoms and determine if the patient is having a potential stroke. If a patient is symptomatic, the emergency department physician is to evaluate the patient immediately. The physician then determines whether the patient is considered a code stroke and needs to immediately go to CAT scan, or they're not and can wait for further testing for another chief complaint. So in my hospital, when we activate a code stroke, multiple technologies are used when they're considered to be a potential stroke. Computerized physician order entry system is utilized to place safe, legible, and complete orders that are approved by our institution. The CPO order set in my work is entitled ED Neuro Code Stroke. We are a designated code stroke center, but we are cannot take out an embolism. This CPO order set generates an alert for the secretary to call a stroke overhead and also to call CAT scan to make sure there is no one on the CAT scan table and to notify them of the need for a CAT scan for the potential stroke patient. This order set also provides multiple tasks for the RN and technician. So technology in stroke, labs are needed. So computer is used to generate the labels for the lab tubes, and they're sent through a tube system. An EKG is obtained, and that EKG is synced into the electronic health record. We use a GE telemetry monitoring for vital signs and cardiac monitoring, which also syncs into the electronic health record. A big component of strokes is checking a blood sugar. So we use a glucometer for blood glucose checks, which scans the patient's bracelet and also syncs into the electronic health record. In our charting system, which is Epic that we use, there is a stroke narrator that's specifically specifically designated to document for strokes and pulls up specific stroke assessments that are related to neurological issues. The CAT scan and subsequent link technologies are used to view scans by the radiologist, and medications administered for a stroke are used by scanning the patient's armband and then scanning the patient's medication, and that links into the computer health system too. We also use stretchers with a built-in scale to weigh the patient because the weight is very critical for the medication administered during a stroke. It is weight-based. So here you can see the workflow analysis for a walk-in stroke at my hospital. The patient comes into the ER and it's greeted in triage. The nurse does a triage and can see that they're potential stroke, which they ask the doctor to view the patient. If the doctor does not think they're having a stroke, they're placed back in the waiting room if they're stable. If the doctor thinks they're having a stroke, they activate a code stroke, and the nurse is sent to the CAT scan with the patient. And at that point, the patient is waiting on the CAT scan stretcher. Pharmacy tries to meet you there. If not, then you call the wait down to pharmacy. Then they have the CAT scan. The patient is returned to the room. And if they need the medication, then the TNK, which is the clot buster, is given there. If they're having hemorrhagic stroke, we prepare for transfer. At the bottom of the screen, you can see the time metrics and time goals for our hospital. Very similar. If a patient comes in from the ambulance, they can give us a heads up, which is LAMS is a stroke scale. And if it's elevated, that means they're having potential stroke. They let the charge nurse know that they might be coming in with a patient who has a stroke. They'll go straight to CAT scan, and at CAT scans where the nurse and the doctor will meet them ideally. When they're at CAT scan, the doctor will assess them, and we will weigh the patient on the stretcher that is kept at CAT scan. If it does not seem like they're having a stroke per the MD, they'll go back to the waiting room, or they might go back to triage, or they might go back to a room if they're still unstable. Patients wait on the CAT scan. That wait is either given to the pharmacist present or called down to pharmacy. And after the CAT scan, the patient returns to the assigned room. If they need the thrombolytics for the clot, if it's ischemic, pharmacy will help with that. If not, wait. So our standards and metrics for our hospital that I work at, which is a city hospital of a magnet institution associated with the Ivy League university, we base ours off of the American Heart Association's goals for ischemic stroke hospital response. And you can see those right here. It's very time dependent because over and over again, we say time is brain. Here is what we use in my hospital to review cases for if we give TNK. This is a blank form, but we can see how we take this very seriously and want to monitor every single stroke that comes through. We look at our workflow analysis, how we can improve it better, thinking that time is brain and 1.9 million neurons are lost every minute a stroke happens. 14 billion synapses are lost. So 1 day of healthy functional life is lost. So time is brain. Speed is key, which needs a very consistent workflow analysis. So since time is brain, there's always room for improvement, but how? The use of AI and triage can analyze the data in the electronic health record to alert the nurse of a potential stroke patient. We also can look at patient waiting in CAT scan for the results versus going from CAT scan to the room and having that window of time lost. And they can receive the thrombolytic and CAT scan to decrease that time. Also, when code strokes are alerted, we can have a designated ambulance waiting for transport in case they need to be transported out to the primary stroke center, since we are a secondary stroke center. So artificial intelligence and triage, how does that work? Well, AI and triage analyzes two types of data, which are considered structured and unstructured. Unstructured data is your chief complaints, your nurse notes, and their past medical history. Structured data looks at vital signs, radiology results, and labs. So delays in care are reduced when the nurse can recognize critical patients. AI can provide alerts for potential stroke symptoms for nurses, and it can identify stroke patients quicker. AI and triage can provide a clear approach during a busy shift or with newer nurses. I found this fantastic flow sheet from an article called AI-Driven Triage in Emergency Departments, a review of benefits and challenges and future directions. You can see AI triage systems helps to have faster care, better decisions, smart resources, and it's a fantastic support for staff. Sometimes we talk about the medicine TNK and CAT scan. So tenecteplase is a fibrolytic that's given for an ischemic stroke. TPA was a medication used for strokes, but is $3,000 more than TNK, so with no difference in results. So TNK is the preferred medication of choice if you're having an ischemic stroke. If time is brain, so you have a 4.5 hour window to give the TNK. If it's longer than that, then there's different medications that need to be used. It's easy to give as a 5-second IV push, and the quicker the patient receives the med, the better the outcomes. The average stroke in the US costs $59,900. So if we can give faster administration of the medications, it will equal less disabilities to the patient and less money. So here is a potential TNK administration for code stroke at the CAT scan. It looks very similar to the ones that we looked at before when they're coming through triage or coming through EMS. But instead of the patient going back to the room, they're waiting at the CAT scan for the results. The pharmacy has the TNK at the bedside, and as long as the patient meets the parameters to receive that TNK, we can give it actually at CAT scan. So the doctor needs to be in the room, the pharmacist needs to be in the room, the blood pressure needs to be in a range, and last known well is established. So if we adapted this approach to our workflow analysis, we're cutting minutes, multiple minutes off of our flow to get the medication to bust up the clots. The nurse's role is always to look for quality improvement and how we can fix workflow analysis. We recognize when technology is a benefit or hindrance to delivering safe care. We can support management when changes are needed to make workflow. It's shown that strong management support enables a better workflow and it helps change. Embracing the mindset that continued workflow analysis is necessary for improved outcomes. Since nurses have the most face time with patients, we have the unique view to identify gaps and brainstorm solutions to create safe, quality, effective care. Provision 4 in the ANA even discusses in the Code of Ethics that the nurse has the authority, accountability, and responsible for nurse practice making decisions and takes actions consistent to help with patient care. So in conclusion, healthcare is constantly evolving to improve workflow and integrate new technologies, all with the goal to enhance patient health outcomes. As nurses, it is important to recognize and adapt to these changes, consistently offering feedback and seeking the bettering of practices. Colossians 3:23 states, "Whatever you do, work at it with all your heart as working for the Lord, not for human masters." Excellence and dedication to patient workflow are a core value and a way to exemplify Christ in nursing. Here are my references. Thank you very much for listening to my workflow analysis of the stroke patient in the emergency department.